Good evening, everyone, and welcome to this fifth session of the 8-week series of the Taping and Movement series brought to you by Elastoplast. All sessions are free and will be presented by industry professionals from a variety of professional sporting backgrounds and physiotherapy specialities. Thank you again for attending tonight, especially when there's a big game of football on tonight, the State of Origin. So thank you very much. My name's Robert Brown. I'll be presenting tonight's talk on the posterolateral corner injuries of the knee. Just give you a little bit of background on myself and my experience and where I come from. So I originally did exercise physiology way back in early 2000s. Did a little bit of work around the AFL scene in Queensland. And then went on to do my postgraduate in physiotherapy studies and then on to Masters in Sports Physiotherapy. First started with the Brisbane Roar way back in 2009 for a couple of years and had great success there. I moved on to the head physio role at Orica Green Edge for 3 years following the World Tour cycling around. Then headed over to London, where I based myself in London, and then also Western Europe, where I helped out with winter sports. So I helped out with the Australian Winter Olympic team and then the Canadian ski cross team. In 2019, I returned back to Queensland and took up a role with the Gold Coast Suns, which is where I'm there now. That did cause a bit of controversy with some of the emails that was sent out calling me the head physio. But I'm not the head physio here and caused quite a lot of stir, especially around the offices. But Lindsay is definitely still here as head physio. Okay, before we get going too, just a little bit of housekeeping. We have the team from Elastoplast controlling today's session. And if you have any questions, please direct them into the chat forum. And because we have so many people in today's session, just remain on mute until the floor is open for questions. But if you have any questions, please send them through, type them in the chat function, and we'll have plenty of time for Q&A at the end and plenty of time for discussion. But also apologise if we don't get to everyone's question. And finally, we'll finish with a disclaimer. Always read the label, follow the instructions for use. If symptoms persist, talk to your health professional. So obviously everything we say here is very applicable to an individual environment. So epidemiology. So posterolateral corner injuries, this is where we're sort of talking about the knee here, so the back and the side of the knee. It's a little bit difficult to get exactly the number of posterolateral corner injuries there is, sort of the prevalence and incidence, because they often occur in combination with other ligament injuries. It's about 2 to 16% of all sort of acute knee ligament injuries will be this posterolateral corner. They also have a really close relationship with the meniscus and the chondral surfaces and also the cruciate ligaments. So about 70% of the ACLs and 44% of your PCLs injuries will also entail an injury to this posterolateral corner area. So this is what we're talking about here. So there's sort of the tibia, fibula head down here. This is your lateral meniscus and this is your femur. So we're looking at this slide directly laterally. And these are what they call the static stabilizers, or your main primary stabilizers of the posterolateral corner area. So you have this lateral collateral ligament or fibular collateral ligament running from the fibula head to the lateral epicondyle of the femur. You have a popliteus tendon. So the popliteus tendon has multiple insertions, sort of collectively called the complex. Although the muscle is dynamic, they do regard this tendon as a static stabilizer. And then the poplitealofibular ligament will run off the popliteus tendon and run down to the fibula head. So they'll form this nice little static triangle at the back here, which will basically lateral collateral ligament resists the varus movement, so the lateral movement, especially sort of 0 to 30 degrees of flexion. The popliteus tendon will resist a lot of varus, and then also external rotation, and then also posterolateral tibial rotation as needed. And the popliteofibular ligament resists varus external rotation as well. It's important to note, but it probably gets really, really complex at the back here of these secondary stabilizers, and these are static as well. Basically, this is all extensions of this posterolateral capsule. So your knee is wrapped in a sort of a fibrous capsule, and it has a resistance as well. And these are thickenings of that posterior and posterior lateral capsule. So some to mention are the arcuate ligament. So this is this sort of expansion here, or this Y shape, which will come down from the capsule and onto the fibula. The oblique popliteal ligament will extend across the back obliquely. Fibullofibular ligament is an interesting one because it'll come up. There's a little styloid bone that sits under the gastroc, and it'll assert onto that. And these meniscofemoral and meniscotibial ligaments are expansions onto the meniscus. So you can see now that we're having sort of the structures are really interplaying with the meniscus here. What they also tend to do is those structures will help the meniscus move and slide out of the way as the knee moves, so the meniscus doesn't tend to catch and guides movement around. These are the dynamic stabilizers at the back. These are really interesting because as a physio, these are the ones you can have a really, really good effect of, especially with the manual therapy and also exercise therapy. So the popliteus muscle, as we've talked about, it provides movement and control, especially sort of that rotation and extension. The biceps femoris, the direct arm inserts onto the posterolateral aspect of the fibular head, and the anterior arm has a small insertion site on more of a distal anterior aspect of the fibular head. But both arms enclose that LCL ligament distally. The medial hamstrings does not have a direct effect on that posterolateral or a direct insertion, but it is said to tension that oblique popliteal complex or lateral capsule, and so it has an effect in sort of helping with preventing hyperextension. The lateral gastroc will wrap and insert up onto the femur, so it'll have a nice little stabilizing effect as well. And the ITB is quite strong and fibrous as it comes down as a superficial layer of the lateral capsule of the knee. And this is just another little diagram here to show you all those structures that help stabilizing the knee. And this one also here shows the semimembranosus coming down and tightening that capsule at the back, and the effect that it can have on extension and rotation at the posterolateral corner. So how do you do these? So this is an example from earlier in this year. Young guy from Port injuring his knee. So what you need to do is a varus, a hyperextension, and/or a tibial external rotation will place a lot of tension on these structures of the knee. It's usually done within a partially flexed knee, and that's because as you flex the knee sort of into that 30 degrees, you'll take the ITB off stretch, and you'll also disengage a little bit of that screw home mechanism, so the articulation of the joint. And it leaves it a little bit more vulnerable to that varus and especially that external rotation of the knee. So these occur very similar to other acute injuries of the knee. So they can occur non-contact, so like we've just seen here, which is an acute episode non-contact. They can also occur through overuse. So this can be small episodes repeated over time. or it can be genetic. And we'll talk about these later. And some people who are sort of genetically varus might just be constantly putting a little bit of pressure on that lateral and posterolateral corner and just constantly stretching those structures. And then we'll have contact as well. So the contact, you'll have this anteromedial force to the proximal tibia. So it causes that rotation and varus movement and also causes a hyperextension at the knee. And so here's a couple of other ways you can do it. So baseball is more common. So what you can see here is the guy's just clipped over the plate and he's hit his foot and he's come into more of an extension or hyperextension. The American football player here, so this is obviously a contact injury hitting the tibia. And the player from Chelsea, quite a famous sort of posterolateral corner injury, which is quite significant in this photo, so non-contact. I've also put a photo here of the ruck contest. So this is one common injury that we get. And this one, you do the posterolateral corner, but it's a lot more common to get a PCL injury in this one, most probably because you're in a lot more flexion and you're getting a direct hit. So the tibia is sort of translating posteriorly directly rather than getting that rotation. But on that too, I will mention the PCL. The PCL is quite a significant structure there, but just we won't go into too much. I think it's a sorry, you got to move with the keep the light on here. So if we move on to subjectively, so what the patient might come in and how you might be able to diagnose one of these if a patient comes to you. So the mechanism of injury is really, really important, but not only seeing how it's done, but also what the patient reports. So they'll report if it's non-contact, they'll report that shift to the side or varus, or they'll explain that their knee hyperextended, or they might have that shift and a little bit of a click or something like that. The pain is usually local, so it'll be lateral, it'll be posterior and posterolateral. It'll be along that joint line or around that proximal tib-fib aspect. Swelling is variable, so sometimes it can swell quite a lot, other times it might not swell at all. And they'll also report sort of a functional instability. So while they're walking, and especially if they're turning or changing directions at a higher level, they'll get this little bit of a slip or giving way of the knee. I think in some ways, one thing that's really important is just not to miss them. I think in some ways, this example here of the AFL player, although it's a bad injury and it's not great, some of the decision making with those kind of injuries is quite easy. It's a big acute knee injury, and the person can't go back on, and you can deal with it. I think the other one is if you have sort of a small incident, not to miss them as well. So there might be something that the person has done mildly, and they've got a little bit of a shift. And then also with your cruciate ligaments, so your PCL and your ACL injuries, is that oftentimes that will take precedent because they're cruciate ligaments, and you'll be testing for them. So it's important not to miss this posterolateral corner, because if you do an ACL and you have a reconstruction, but you still have instability in the posterolateral corner, you might have a failed outcome. And one really good example that we had this season was one of our players reported a small incident, and I think the objective assessment on the sideline was a little bit inconclusive. We knew something had happened sort of internally with his knee, looking at this posterior and posterolateral area. But what really, really helped us was the patient and the reporting of that mechanism of injury, and the fact that at the time of the injury, what he felt, and then also when he started walking again, feeling just not right around that sort of proximal tib-fib joint and a bit more excessive movement. that kind of information really helped us make the best clinical decision for him. So on to sort of a physical assessment or an objective assessment. So these ones, obviously they're going to stand out a little bit, but you might notice them as you walk into the clinic or when they're in stance, that they'll just hang back on these passive structures. So they don't really have any, or they don't have any good tension in their passive structures at the back, and they'll sit in that hyperextension. And if that's too bad, then they'll actually compensate. And so they'll flex the knee, they'll walk on their toes. And what they're doing here is they're putting themselves into a bit of flexion, internal rotation. They come up on their toes and they use their gastroc, and they'll just push off that. But obviously these, you don't want to miss these guys as they walk in your clinic. And that's a little bit of a giveaway, is that something might be amiss to those passive structures or even dynamic structures at the back. We're talking a little bit more about sort of those small overuse injuries as well, and not to miss them. So another way that if they have an injury to the posterolateral corner, they'll have what they call a varus thrust gait. So if you can imagine someone walking, they go into the extension, and instead of having a nice sort of passive stability at that extension that they can then propel from, it's a little bit lax, and they'll go into a hyperextension and a varus. They'll gap into varus, and then they'll sling off it. And this is a really good example of someone who has sort of a mild case of it. So they might not have had an acute injury, but they're getting that varus. They might have had a few small episodes over a long period of time, and it's been overused, an overuse injury. And so that's how you sort of tend to see them walk or run. And as you can see here from the video, is that you'll often these kind of patients, a lot of the times they'll actually complain of knee pain elsewhere. So they might even have hip pain or foot pain, but knowing about the posterolateral corner and knowing about the dynamics at the knee has really helped me sort of understand injuries around the knee, hip, and foot a little bit more. And we'll speak about that a little bit more as we go through the tests. So these are the special tests that we use to really help diagnose injuries in this posterolateral corner area. It's important to note that these are just a gamut of special tests. They're not an extensive test, but they do make up the whole of your objective assessment. And these are tests that I actually use in pretty much all my knees. So even if someone has an overuse patellofemoral issue, I'll still use these because they really give you really, really good information about the laxity of the knee, especially into extension and rotation, and then helps you understand sort of how the laxity of the knee might be influencing the mechanics when that person is loading. So there's just a straight varus test. So it can be done at 0 degrees and 30 degrees. And then it's looking for basically LCL. So what you do here is that if the test is positive, they can have symptoms, but it's also the degree of gapping. And we'll talk a little bit later about that degree of gapping, because that will help you then clinically make better decisions about what the treatment options are further down of how much the laxity is. So it's done at 0 degrees and then 30 degrees. So as you do 30 degrees, you take the capsule and the ITB off tension, and you'll get a lot more specific LCL. I'll also do one with a posterolateral corner bias. So if you think about that posterolateral corner bias, so rather than doing a straight varus, I'll actually put it into extension. So then you can do a hyperextension. You can then add a little bit of external rotation, and then you can actually bias your force down towards the posterolateral corner area, and then you can feel the gapping sort of just behind posterior to the fibular head along the joint line. This is the dial test. So this one is really, really good for diagnosing or differentiating between the PCL and the posterolateral corner. So with the patient in supine, you start. These are back the front. So you start with 30 degrees of flexion here, and then you externally rotate the tibia via the foot. A posterolateral corner injury will be determined is if it's 10 degrees more on one side than the other. So you think, okay, you've got more external rotation on one side than the other. You then keep that external rotation and you bring the knees and you flex them up into 90 degrees. So if the external rotation that started at 30 degrees decreases and the external rotation stays the same, then you've just got a posterolateral corner. You don't have a PCL. However, if you have increased external rotation at both, then you have both the posterolateral corner and the PCL. And the reason why this is as you flex the knee, the PCL will tension and it will internally rotate the tibia. It's got really, really good intra and intra-tester reliability and validity as well. So it's quite a really good differential diagnosis test. Reverse pivot shift test. So the pivot shift test is famous for the ACL. So this is nearly a reverse. So you bring the knee. So you think about the mechanism of injury and how you're going to bias or stress those structures at the posterolateral corner. So you bring the knee into flexion and then you externally rotate the tibia and you add a little bit of axial load. And what this will do is if you're injured in that area, it'll actually sublux the posterolateral corner. You then, keeping that tension on, you bring the knee through extension, into extension. And what will happen is about the 30-degree mark, the ITB will kick in and it'll pull the knee back out of subluxation and back into position. So you'll get that shift as it comes back into place. And this is also really good. I've seen a lot of orthopedic surgeons not only do this for the subluxation and how positive the test is, but they'll actually do it nice and subtly so they can actually pick up how much laxity there is into rotation. And that's sort of that laxity into rotation they like to use as a determinant for whether or not the person will do well surgically or conservatively. This is another interesting test that I've used more recently, and the frog test. So you just bring the patient's knee up into 90 degrees, their heels are together, and let them sort of abduct outwards. You can place, if you think about the mechanism of injury for contact, so you're applying an anteromedial force and then directing it posterolaterally, you can have your finger on that joint line here, and you can actually feel that that laxity within it. It's not a bad test, but it's hard to get a bit more external rotation because the thigh is out, and so the thigh is externally rotating. So sometimes it's hard to get more external rotation at the tibia. I've actually found this a really good. If someone is stiff or you want to treat through that area, I've found this is a really good position to actually treat the posterolateral corner in. And this is just a hyperextension test. You can do it just grabbing the toes and bringing it up. So obviously you're going to get a lag, probably more PCL, but you can also, it's just a very, very gross test to estimate the person's viability through those structures and see if there's any difference. You can place a hand on the thigh here, but it then becomes a little bit more of an anterior draw of the tibia. So you're probably looking at more ACL. But as I said, it's a good sort of looking at the integrity of that extension through the knee. And this gets back to a little bit of how I've sometimes used or quite commonly used these tests in my examination. As we're talking about, is that even if the person hasn't had a direct trauma to the posterolateral corner, it can have a significant effect on the mechanics of the knee. And one really, really good clinical case that I came across a couple of years ago was a guy who had some chronic patellofemoral pain syndrome with some ITB friction syndrome as well. He'd had it off and on for 2 to 3 years, had no success. He's been through all the patellofemoral training programs, doing the quads, doing the glute med, lateral stabilizers of the hip, had his orthotics in, everything like that, and still wasn't getting much success. I used a few of these tests, and from those tests, you can determine that laxity. And he tended to have a little bit more varus, but a lot more external rotation and extension of the knee compared to the other side. So based on this, and based on sort of using those dynamic stabilizers that we talked about before, you can test the hamstrings. He was a little bit weak through his hamstrings, especially laterally. We did a lot of hamstring training, and he had really, really good success because he was able to control this rotation at the knee and reduce his loading through the patellofemoral joint. And I thought that was just a really good example of how using those tests for a sort of an acute injury can really help with other conditions around the knee. Imaging is really, really good and recommended, especially with these acute injuries. As we said, and as we've seen, there's a lot of different structures at the back of the knee here. So determining which ones are injured and how injured they are will really determine your clinical decision making and how you want to proceed with treatment. This one here is an LCL. And this one here is a good example of how different structures can be injured. So this one here is the white arrow is your LCL injury. The orange yellow is an avulsion of the popliteus off its insertion. And then the black arrow is the lateral capsule. And then you can see the continuation or the communication with the lateral meniscus. This one here is the varus stress radiograph. So this is a good way. It's not really commonly used in acute injuries, mainly because MRIs are good enough these days where you can actually tell which structures are injured and how much they are injured, so how much fiber damage is involved. But this one's really good, especially for for chronic conditions. So basically, they do a varus stress test at 20 degrees under an X-ray, and they're testing the difference side to side. And depending on the opening of that lateral joint line will give you a good rating of how lax the knee is and then whether or not surgery is involved. These are the grading scales that have been published in the literature. Probably the one that we're most common with is these rating scales of 1, 2, and 3. And that's just what we were talking about before. It's the amount of laxity that's involved. But overall, your decision-making needs to be based on this laxity. It needs to be based on subjectively how the patient is feeling and functioning, whether or not they have subjective laxity, giving way, slipping, etc. And it's also based on how many structures of this posterolateral corner are injured, if it's just an isolated ligament or it's a combination of a few. And here's a little flow chart for clinical decision making that is quite relevant and really good. So we tend to have grade 1, grade 2 if they're an isolated injury. They do quite well non-surgically and with bracing, etc., and then a good rehab program. This one here where it says avulsion injury or high demand, so that's obviously a pull off the bony attachment rather than an intersubstance fiber strain. For grade 2 combined injury, so especially if they've got a PCL, ACL, especially if they've got a meniscus or several structures at the posterolateral corner that are injured, and then a grade 3, so a really high level gapping of the knee joint, then surgery would be required or recommended. It's really important around the timing of these timing events. So you've got about 3 weeks to make a decision. After that, they tend to become chronic, and you'll have to do a reconstruction. But what will happen is the alignment of the knee becomes the biggest issue, and you'd be having a look at like sort of a tibial osteotomy after that. So those guys that have that really, really chronic overuse and they've had a varus thrust pattern for a really, really long time, just repairing that structures at the back will give them some stability, but it probably won't help them too much. You'd have to looking at a sort of a realignment. Now, as we said, so the grade 3 to grade 2 probably go to an operation. There's a reconstruction versus repairs, and that's just based on what types of structures are injured and how much they're injured, and you make that decision within the 3 weeks. And this is about the conservative. So we said the grade 1 to the grade 2 injuries do well. You're looking at about 2 to 6 weeks. So the 2 is would be those grade 1 or low grade injuries, and 6 weeks would be sort of those isolated grade 2. Prevention, hyperextension, obviously, varus and external rotation. And then you follow with once they've stiffened up in the brace, and then you follow a really, really good rehab program. What I've included here, so as we talked about, the quads will be really, really important because the quads are going to help stabilize into extension or prevent extension and be a really good garter of that in the knee. And then hamstring training or reloading is really, really important, as we talked about, and especially the lateral hamstring, so that biceps fem with its insertion directly onto the fibula head and its communication with the capsule. And a couple of exercises I've shown here is that are really good. So if you want to bias the lateral hamstrings, you go hip base, so that will give you more biceps fem, and then you add a little bit of external rotation, which will then bias the lateral hamstrings a little bit more. And then a lot of calf training we found is really good in standing to get that gastroc operating really well. The gastroc, as we saw, especially that lateral proximal gastroc, will come across and really help protect that posterolateral corner of the knee. Taping. So all our guys coming back, whether or not it be surgical or conservative, we have really, really good results getting them back on the track without too much symptoms, with a good amount of strapping around the knee. So the one here on the left is a extension, just an extension block. And so we find that really, really good just in closing the knee, just helping preventing that hyperextension and giving them a little bit of feedback in that posterolateral corner area. The other way we can do it, so this one here is an LCL, so just you're using your axis here, you'll cross over and you'll go straight onto the LCL, so that's really helping with the varus. But then we also do a posterolateral one, and I couldn't find a photo, unfortunately, and basically using your axis and you cross over that posterolateral corner area. If they've got a lot of instability and they're coming back from a decent injury, then we'll do an extension block and a posterolateral corner block as well. We also like to, you can combine it or do this in isolation. And this is just the working on that proximal tib fib, because obviously the proximal tib fib is quite concerned with that posterolateral corner area. And you working on the mechanics of the knee. So this is an AP. So this will help with that sort of external rotation and flexion of the knee. And then if you're looking at a PA, then it'll help with that internal rotation or helping prevent the external rotation, and also helping with that terminal extension. Excellent. Thanks very much. And these are a few review articles that are really, really good, where you can find a lot more information and a little bit more detail around the posterior lateral corner of the knee. Yeah, we've got a couple of questions coming through, just on the rehab, regarding sort of what you're going to use as your resistance. Yeah, any kind of resistance bands are really good, and basically varying them. So one resistance is not better than another. So if you're using a cable or a resistance band, or like a leg curl or something like that, you're just thinking about where you want the resistance and what your goal would like to be. So with resistance bands, they're obviously really light at the start of movement, and then as you bring them or tension them more, then the resistance will come on more. So they're really good for altering resistance through range of motion, but they don't have a consistent resistance through range. So probably the best answer is a little bit of both. For example, if you wanted to use a resistance band for, say, a hamstring, it'd be good more you flex, but obviously you want a nice resistance, probably more at that end range, where you're going to have the most tension on the hamstrings. Yeah, so question around taping and bracing. So I guess the way I understand the question is, um, you can definitely use tape as a straight after the injury as a support, absolutely. Um, the difference being is that obviously with a brace, it's quite easy to wear around all the time. You can wear it to bed, etc., and then you can take it on and off. The strapping will support the region, but obviously you have to have the strapping done um, nearly every day. It's also about skin condition as well. So having tape on your skin for a long time or 6 weeks might not be great for your skin. But definitely after an injury, or it's a really good way as a diagnostic tool. So say we'll have a player come off, we do the assessment, and we deem them that it's not a high grade injury. So say you might have a grade 1 or a low grade 2 injury, and they have really good function. We can actually tape them on the sideline, and that will allow them to continue. But it's also a nice diagnostic tool. So if you tape them and they feel really good, then you know, okay, there might be a little bit of laxity there that we need to address from there. But yeah, it's also, tape is also a really good diagnostic tool. That AP and PA tape of the fibula is also a really good one that we use to help promote movement of the knee with the coupling of the mechanics. Around return to play and return to sport, the rehab guidelines, obviously, they differ considerably from person to person, injury to injury. But around a rough rehab time, unfortunately, the Xavier from Port Adelaide, who did his LCL, that was a LCL, really high grade. That's about all I sort of know of that injury. And he went to surgery. So he did it on April the 10th, and he'll be back in about 4 weeks' time. So we're looking around that sort of 12-week mark, and that's surgical. With our guys, we look around that sort of anywhere from 12 weeks at the latest. The low grade ones will get back even quicker. But one thing one thing that we found with our rehab is that, or clinical decision making, is that you want to go one or the other. You don't want to get stuck in the middle. So if you're going to go conservative, or even if you, so if you're going to go conservative, make a decision on how long you want to brace them. And if you want to brace them for 6 weeks and you really want to get those structures nice and tight and get good stability, then do it for 6 weeks. Then your rehab will be, they'll be back in about 8 to 12 weeks. But if you make the decision, I want to brace them for, say, 3 weeks and then get them back, then they sort of land in this in-between time. So they'll have about a 6 to 8 week return, but they won't be very good. And so if they're not going to be very good, then you might as well have got them back within that 2 to 3 week frame. That's just sort of what we've experienced from our time. So I think we'll wrap up tonight's session. Thank you very much for all tuning in. It's been great. For any products on the Elastoplast and Leuko range, please go to your local pharmacy, sports wholesaler in the state, or Elastoplast online store, elastoplast.com.au, and you can purchase all of the products, Elastoplast and Leuko products, online. For further instructional videos, visit our YouTube page, search Elastoplast ANZ, subscribe and like, plus you'll see all the videos from session 1 of the Elastoplast taping and movement series. So the next session will be on Wednesday, the 30th of June at 6 p.m. With South Sydney Rabbitohs head physio, Eddie Farrer. And he'll be talking about the topic of returning to training following injury or surgery.